Alright, good evening class. My name is Kyle Molnax. I'm going to be your instructor for this period of instruction. For instructor methodology, this would be for my 45-minute presentation. As of current, I do work for Onslow County EMS. I am a paramedic. Been a paramedic for about 7-8 months now. Prior to that, I worked same with Onslow County EMS as a advanced EMT. And then previous to that, I was with Lenore County as both an advanced EMT as well as an EMT basic. I've been doing this for about 3 years now. I also am a adjunct instructor for Coastal Carolina Community College, and I've been doing that for a little over 2 years, mainly for the EMT class. Hoping to move up into AEMT and medic here shortly. So in this period of instruction, I'm going to be going over RSI, DAI, depending on what your department does and what you guys call it. So we'll kind of go over that, and then we got some prac app, and we'll kind of do some prac app and showing how the actual RSI, DAI works. So without further ado, we'll go ahead and get this started. So instructor methodology, RSI, DAI. Alright, so in this period of instruction, you should learn what is RSI, what is, or DAI, and in the next slide I'll kind of go over a little bit of the difference there. Why do we RSI or DAI? The contraindications, setting up, which I've also got the tools so we can go over setup as well. The procedure in actually doing RSI/DAI, as well as paperwork following. There's always going to be paperwork. It's always the dreaded paperwork. So, what is RSI or DAI? So RSI is the administration of pharmacological agents, including paralytic agents, to facilitate endotracheal intubation. So this is when you kind of have that time. Most departments do this. DAI is the administration of pharmacological agents, excluding paralytic agents, to facilitate endotracheal intubation. This is when there's an emergency and you need an immediate ET tube, and the benefit outweighs the risk. Say somebody who has a closed up airway and can't breathe at all, things like that. So why would we RSI or DAI? Inability to maintain airway patency, and that kind of goes into the second part as well, the inability to protect the airway against aspiration. Airway patency, you've got your allergic reactions, you've got your asthma, things that are going to close up that airway, and you need to get that airway open so that you can breathe for the patient. And then of course aspiration as well. You get that seizure patient who starts vomiting, they can't protect their own airway. You get that that person who their jaw locks up, you can't get that jaw open, you might need to RSI. You also got those people who are unresponsive and they start to aspirate. And then failure to ventilate. Sometimes your King airway, your eye gels, and even sometimes your BVM, you're not getting good ventilation. You're not able to get that SpO2 up. You're not able to get that end tidal up or down, depending on where you need it to go. You might need to RSI. A lot of things you see on RSI is going to be your CHF exacerbations or your COPD exacerbations. Two different ways. That's kind of like when we go into inability to maintain an airway patency, that's your COPD, and then your protect against aspiration, that's your CHF and your flash pulmonary edema. Failure to oxygenate, that goes into ventilating. I'm sitting here and I'm squeezing that bag. you know, and as I'm squeezing it, I'm not able to get that SpO2 to come up. There's a reason for that. Something's not right that's not allowing that oxygen to get into the bronchioles, get into those lungs, and therefore you might have to tube this person to help them with breathing. And then, of course, anticipation of deteriorating that will eventually lead to respiratory failure. Again, we went into our CHFers or COPDers. A lot of this will be on anticipation when, you put them on CPAP/BiPAP, however you do it. You've given them the MAG, you've given the Solumedrol, you've given the Duoneb, and nothing seems to be working, and they're still sitting at 79%, and they're getting real tired. That's anticipating. We're going to go ahead and anticipate that this person might need RSI or DAI. So, what are some of the contraindications for RSI or DAI? So, predicted inability to maintain and adequately manage the airway with a BVM. So, which we'll go over later is your lemon and your Mallampati score and all that stuff. So, if you don't think that you're going to be able to get that tube, and you're looking and you start going over your lemon, you start going over your Mallampati score, and you're just looking, you got your bull neck, or that's possibly one of the reasons I'm not going to RSI or /DAI, and we'll have to figure out where we're going to go from there. Severe facial trauma, when there is loss of facial or oropharyngeal landmarks. If I can't get in there and I can't see what I'm trying to get, because I'm going to have to pass that tube, through the trachea. If I can't see that, I can't adequately do this part right here. I can't tube this patient because I don't know where I'm going. I don't know where I'm passing that tube, and I could possibly get that tube into, I could push it into one of the lungs a little too far because I don't see where I'm going. I could push it into the stomach and cause some trauma there. So, and then children under the 12. This is kind of a tricky one because we all know that puberty has started to hit children a little earlier on. So the children under 12 is kind of a tricky one. It's I don't want to say provider discretion. However, if you've got a, let's say a 6'2", 250-pound football player in high school. Well, we can't use high school. 8th grade. I mean, I've seen some pretty big people in 8th grade, 9th grade. So that's when you can kind of make a judgment. Hey, I'm going to call medical control and kind of ask what I've got there. Again, this comes down to your policies and your procedures. You'd have to look at that for your particular agency. So, all right. So we talked about lemon and Mallampati, which is part of your lemon. So we got look externally, evaluate. So can the patient fit 3 fingers between their incisors? So here, is the mandible 3 lengths, and the distance from the hyoid to the thyroid. Then your Mallampati, we have 1 through 4. Do I open up that airway and can I see those cords well, or do I kind of need to pull up and move that tongue out of the way, and I've got to kind of work. So your Mallampati score will dictate, remember we talked about if you can actually do RSI or DAI. Obstruction or obesity. We talked about, the bull neck. Some people walk around and they've got that bull neck. That kind of goes into Mallampati. Usually if they got that bull neck, they're a little bit obese. It's going to be harder. They're going to have that Mallampati score over a 4. So, and then neck mobility. So we'll kind of go over it when we actually do the prac app. However, neck mobility, you want to try to get that head up. A lot of people will place pillows behind the neck in order to actually do the RSI process or DAI process, and that kind of opens up and allows you to look in there. You can do it in a C-collar. It is done, however, not ideal. So there's kind of what we talked about right there. Look, evaluate Mallampati score, obstruction or obesity. Is there an obstruction? I mean, if that airway's too closed up, do we need to go to a crike, or where do we need to go from there? So, and then the neck mobility, like we said. The other one is actually setting up for your RSI/DAI. So we go by the mnemonic BB blessed P. So that's going to be your BVM. So want to make sure we have a BVM, depending on what your, and of course oxygen with that BVM. Do we have a bougie? In case I can't get that tube, I want this bougie. That's going to make it a lot easier. Again, when we get into prac app, we'll kind of go over that a little bit more. You need your backup airway depending on what you carry. Some people carry combi tubes, eye gels, Kings. So we want a backup airway in case we can't get that tube. We want our laryngoscope or a king blade / a king blade. Some departments you can only use a king blade in RSI. Some you do not have to just use a king blade. It's going to have that light on the end of it. You can do Max Millers. So just picking the blade that you kind of want to pick. And then, of course, your king vision with the blade. So this is going to, and we'll go over that again. This is going to have the screen on it. It's going to allow you to actually see those vocal cords and pass through. Your ET tube. Okay, you're going to want your ET tube, and that's going to be also one size up and one size down. These you can kind of base off size of the person, as well as their Mallampati and kind of their obesity and everything like that. Those smaller people, I know for women it's usually a 6 to a 7, and men it's normally a 7 to an 8. I usually get a 6.5 to a 7.5 and have those ready. Your stylet usually does come inside of your ET tube. It's going to look like that. It's going to go inside your ET tube to help you kind of move that through the vocal cords, as well as your syringe. Now this says a 10 ml syringe. You can really use whatever syringe you got. You can pump it to where you need to, as well as suction. We always want to have your suction, as well as your hard catheter or your hard suction, as well as your French catheter, so you can go down that tube if you need to. This is also the blade for your video laryngoscope. Your SpO2, of course, that's going to be attached to your monitor. You're going to want an SpO2 anyway. End title, it's going to go on your bag. Some people still use color metrics. I do believe in a lot of places they are still required to carry on a truck. So you still have that color metric as a backup. to your end tidal. Of course, lung sounds, epigastric sounds, stuff like that, you of course want to check as well. Then comes your drugs, your ketamine, rock, succinylcholine, whatever you use in your agency. I know some agencies carry all of them. Some agencies only carry one or the other. And then your post-intubation sedation. This can be, you can continue on with your ketamine. You can use fentanyl, you can use Versed. A lot of people kind of continue on with the ketamine. You've already got the dosage, you've already got the medication open, they've already had the ketamine. So a lot of people do stick with the ketamine, but it's whatever you prefer or whatever your particular agency uses. So, and then of course all your P's. Your when you get into all this, so before we even start to think about RSI, DAI, we're going to need to go over our BB plus P. Take a second, go over this, make sure you have everything. Then once we get there, okay, now we're getting ready to do everything. Your preparation is you're going to be your BB plus P, your pre-oxygenation. A lot of people say to hyperventilate. Do not hyperventilate. Pre-oxygenate. Get their SpO2 up. And usually you do about 2 breaths every 6 seconds rather than 1. Your pre-treatment, so you're going to do your not your paralytic, but your sedation. You do your sedation, then you'll do your paralysis. Do not do your paralysis prior to your sedation. Positioning, again, we talked about that. Putting a towel under the head if you need to, being able to see those vocal cords and everything. Your placement, and then you notice I put in here proof of placement. When I talk about proof of placement, we talked about you're going to have your end tidal. If you can get all of them, end tidal, colorimetric, lung sounds, epigastric sounds, condensation in the tube, we want to look at everything we can to know, and then of course our direct visualization of passing the cords. Those are going to be our proof of placement. Again, we talked about paperwork. This paperwork is going to ask you about that. So definitely you want to know about your proof of placement. That way when you get that doc signature, or if you're asked about it by your medical director, so on and so forth, then you can actually have your proof of placement. Then post-intubation management, which is going to be your post-intubation sedation, your ketamine, your Versed, or your fentanyl. All right, medications used. We kind of went over that in our last ones, what our medications are used. So ketamine, dissociative anesthetic. Now again, this might be a little bit different in your department. So dose is 2 milligrams per kilogram, and you can repeat one time. Contraindications is going to actually be hypotension. So there's a little typo in there. That's my fault. It's going to be hypotension. You got your rock. So that's a non-depolarizing neuroblocker. Your paralytic. For this particular thing, your dose is 1 mg per kg. Your contraindications, use caution in heart and liver disease. Now, a lot of these contraindications aren't necessarily contraindications, they are cautionary. Make sure we're kind of keeping an eye on some things if we're given this medication. I'm sorry, go back on that. All right, your sucks. We say sucks. A lot of people don't like it. It's a skeletal muscle relaxer. You're paralytic. Here the dose is 2 milligrams per kilogram. The reason sucks is because of your contraindications. Malignant hyperthermia. Lumpy Indians are usually the people who get that. So a lot of textbooks will say lumpy Indian, not necessarily malignant hyperthermia, but that's why, is because they're more prone to it. Your burns, your major traumas, and your hyperkalemia. And then your etomidate. A lot of people don't like etomidate because of how short it acts. Your patient starts coming around, starts bucking the tube. Now you kind of keep having to try to get that patient to go back down so they don't throw the tube. Dose is 0.3 milligrams per kilogram. It's your anesthetic, and some of your contraindications, it's going to be sepsis, and that's because of your adrenal suppression. So now, this says what medications do I use. This isn't necessarily saying you need to use this medication for these particular things. Again, some people only carry the one thing or the other. So it's not saying that, it's just saying what is best to use in these your perfect case scenario. So your major trauma, ketamine and rock. Your coma or MI and a lower BP, etomidate and sucks. Your coma or hypertension, etomidate and rock. And your septic shock is going to be your ketamine and your sucks. Again, it's not saying that you cannot use one or the other. It's just stating that these are what they've shown to be best in these particular scenarios. All right, so induction. Medication used to initiate anesthesia, the transition from consciousness to unconsciousness. This will be used first in your RSI DAI. So we want to go ahead and can you imagine being paralyzed, not being able to do anything while something's being shoved down your throat? A lot of people, they paralyze first, and that person cannot do anything about it except for basically just lay there, and they're in excruciating pain. So we need to make sure that we consider all this when we're starting to think about, and not just rush. That's why we all get set up. We make sure we have everything and we do everything right. So your ketamine. Your ketamine, when you want your pressure up and the heart and body can tolerate an increased BP and heart rate, then you would want to choose ketamine if you have that option. Etomidate, when increased BP or MI, myocardial O2 demand puts the patient at risk, choose etomidate. In other words, when they're hemodynamically unstable. So your paralytic, we talked a little bit about paralytics. This is your powerful muscle relaxants that are used to prevent muscle movement during RSI. This also helps with aspiration as well. This kind of lets them relax. A lot of times when the way you're going to see is you're going to start moving the jaw. Once we see that jaw relax, we're going to be able to go ahead and go through with the RSI. Your sucks, remember we said sucks. Your indications are no contraindications, no concern for muscle fasciculations, and need for a short apneic time. Predicted difficult airway, hemodynamically unstable, and poor cardiovascular reserve. So, your CHF when your preload or your afterload is off. You want to try to use sucks. Your rock, we kind of went over trauma, head trauma, chronic renal failure, your neuro disorder, i.e. Stroke, spinal cord, muscular dystrophy, myasthenia gravis, your crush injuries, and your major burns within 1 week. So we'll use rock at that time. Talked about post-intubation sedation. Again, a lot of people stick with the ketamine just because they've already got it drawn up, they've already got it ready. However, you can use your Versed, which is your benzo. Doses for our particular agency, 2.5 milligrams, max 10 milligrams. You can repeat 3 to 5 minutes as needed. Your fentanyl, which is a narcotic, analgesic, doses 1 microgram per kilogram to a max of 300 micrograms, and then you can repeat in half doses every 10 minutes as needed. I'll come back to this push dose epi, and I kind of put it in here as a post intubation, but we'll go over that. Your ketamine, we're going to stick with the 2 milligrams per kilogram, or your etomidate 0.3 milligrams per kilograms, and I put not for pediatrics. Again, we want to try not to do anything under the age of 12. However, again, med control, I've got a 150-pound person that already hit puberty, and we need to look at that, and they say go ahead, this isn't for the pediatrics. Now I put push dose epi in here because we talk about some of these can drop the blood pressure drastically, so we want to have that push dose epi ready in case that happens, and we can turn around and we can get some push dose epi, and we want to keep that systolic above 90. And then we also want to consider, does this patient need blood products if your system happens to carry blood products? So, and then right down here, I kind of put this off to the side. Consider a long-term paralytic, like rock. Again, put in there not for peds, but your rock is going to be 1 milligram per kilogram. So, all right. So I kind of got a video in here. This will go over it, even though we will go over it
that the
as well.
laryngoscope is working and the cuff on the tube inflates and deflates properly. Pre-oxygenate the patient with bag and mask ventilation for up to 1 minute before attempting to intubate.
And here's your pre-oxygenation.
Standing behind the patient with the head in the
positioning
position, with the left hand, insert the curved blade of the laryngoscope into the mouth over the right side of the tongue, displacing it to the left and upwards. Advance the laryngoscope slightly until the tip of the epiglottis can be seen posterior to the back of the tongue. Advance the tip of the laryngoscope blade into the vallecula between the epiglottis and the tongue.
We're going to push up.
With the handle of the laryngoscope pointing away from you at 45 degrees, lift upwards and away to lift up the tongue and epiglottis to display the vocal cords and the laryngeal opening. With the right hand, insert the endotracheal tube from the right-hand side of the mouth directly between the cords and into the trachea until the cuff passes through the cords. The markings on the tube at the incisors will show between 21 and 24 centimeters in the average-sized adult when the tube is in position. Remove the laryngoscope and inflate the cuff with approximately 15 mils of air to prevent air leaking during ventilation. Attach the tube to the bag and valve apparatus and ventilate the patient with the oxygen flow of 12 to 15 litres per minute. Confirm the position of the tube by auscultating over the apices of the lungs, the axillae and the stomach. If it is not in the correct position, deflate the cuff and remove the tube. Resort back to bag and mask ventilation and repeat the intubation process from the beginning.
Some places you only get 2, possibly 3 times.
The right lung will be ventilated only via the right main
That would count as 1 time.
If this occurs, deflate the cuff and withdraw the tube 2 to 3 centimeters. Re-inflate the cuff and recheck the position. When the tube is in the correct position, tie it in place with cotton tape and attach the tube to the ventilating apparatus
or
and ventilate the patient.
Your tube holder. So, again, lung sounds, uppers, second and third intercostal, mid-clavicular, fourth and fifth, mid-axillary, and then, of course, epigastric sounds, making sure you don't have anything in your epigastric. So. Talked about paperwork. You've done it. Now we've got to do the paperwork. our system, as well as I'm pretty sure any other system that RSI or DAIs, your paperwork is going to come up to the medical director, the state medical director. It's going to come up through your local medical director as well as your state medical director. I know in our county, anytime we even use ketamine, it goes up to our medical director, it comes up to our training officer, it comes up to our QA, it comes up to everybody that we even use ketamine. But like I said, the paperwork on RSI is very detailed because that's, if you have too many that fail, too many things that go wrong in your county, they will pull your RSI/DAI, and nobody will be able to do that. And that's taken away from your patient. That's taking away something that could possibly help your patient. We don't want to do that. Which, your paperwork, that is going to consist of, remember how we talked about, it's going to consist of a doctor's signature. It's going to consist of where your tube was placed at how many centimeters. It's going to ask who did the RSI DAI. It's going to ask the drugs that were given as well as the doses given. It's going to ask you all these questions. You're going to have to answer all these questions, which is why it's so important to make sure you keep track of what you did. With that also, again, our particular system, it uses, we have a medical director review after any RSI DAI. It's not to get anybody in trouble. However, it is to make sure that everything done was correct. Is this the route we definitely needed to go? So yes, paperwork is very important, and everybody's going to have to do the paperwork. And if you do not, there's going to be some consequences on that, especially from the state medical director. So if I have no questions, which I'm sure I'll get some questions in the comments, we're going to go ahead and move on to the PRAC app portion. Okay, so you're going to see me kind of move this. I'm going to go ahead and move this here. Go ahead and turn it around. And I do apologize, I don't want to make y'all sick. Alright. Kind of talked about setup. So, we've got our BVM, we've got our tube holder. So, we've got, of course, a couple different airways. We've got our OPA, NPA, which should probably be in place prior to actually doing it. If you're bagging, probably get that in place first and foremost. We've got our backup airway. Got our stylet, and for this I only have the one. It's a 6.5. My stylet, my ET tube. Okay. I've got both my types, both of my blades. Now with the video, this just kind of slips right on here, and this is what we call a channel blade. It does have the channel here, so that tube will actually sit right here in this channel. Right there and there like that. Okay, so when I turn this on, you want that tube to barely be in your right hand corner. Okay, so, and we'll kind of go over that. Now for this particular demonstration, I also have my my normal Mac blade. This is a Mac 3. You can tell because it's got the curve. A Miller is going to be straight. It kind of comes down to preference. Make sure your light's working. I've got my syringe. I've got my end title, I've got my bougie, and I've got my suction here. So I've got everything I need. So what we're gonna do is, before we even do anything as far as innovation, I'm gonna go ahead and I'm gonna make sure all my stuff works. Does my cuff inflate? Does it stay inflated? Okay, on both of them, on both this and my backup airway. So here, got my king. I want to make sure my backup airway is. Backup airways usually take a little bit more, or your kings. So make sure it inflates. Make sure it stays inflated. We want to make sure all that's done that way. We're not sitting here putting it in and that balloon doesn't blow up, and now all of a sudden you're trying to scramble to get another one set up. I go ahead and stick my end title on prior. Prior to, okay. This particular one has PEEP already on it. So, all right. So I've got all my stuff set up, right? I'm gonna turn it this way so y'all can see. Put all this stuff over here because we're going to go over the actual innovation portion. We're not going to worry about a backup airway. So we'll put that this way. Put that over here. I need all this stuff. All right. So you're always going to hold your blade or your king vision in your left hand. Kind of sucks if you're a righty, but you always want that in your left hand. So I'm going to go ahead and I'm going to turn on my, and we'll get a better angle here in just a moment for you. But again, I'm going to get that just enough to where I can see it in the right hand corner, okay? What I like to do is go ahead and hook up my syringe and I can put it right in here, okay? So we talked about positioning. I want to try to get that head back, kind of like we're doing, opening up the airway, head tilt, chin lift, okay? I'm going to come in and I'm going to find those vocal cords. I'm going to get just on those vocal cords. Now you also need some lube. Once I get on those vocal cords, and if you do go too far, it will let you know because it will not go in there. Visually saw. We're going to go ahead and blow up. All right, so as you can see, I'm in the stomach. Okay, when I auscultate, I'm going to hear epigastric sound. So I'm going to want to pull that tube. Again, you're going to want lube. If you do not have lube, it makes it 1,000 times harder. If you happen to go twice and you cannot get it, don't be too proud. Find a medic who's done more of these than you. Find a different medic. It might not be your day. So you want to find that medic to do the best outcome for the patient. Okay? So we're going to look. We're going to get just on the vallecula. All right. So we pass through the cords. Once you get this in here, do not let go of that tube. Okay? Hook the oxygen, and we're going to inflate. Both lungs are inflating. Okay? Equal chest rise and fall. Got my end total going up. We got condensation in the tube. Using a color metric, however you guys do it. And we're going to make sure that tube is placed properly. And I am at 24 at the teeth. Remember how we talked about those lines? We want to mark that down on our paper that we were 24 at the teeth. Okay? So once we get that actually done, we've got our tube holder. So we want to get that tube holder in there. Make sure we do not squeeze off this in case we have to do anything as far as pulling that tube, inflating, anything like that. So we're going to lock down that tube holder. We're going to come around the back. We're going to tie off that tube, making sure that way it doesn't move out of your patient's mouth. Anytime we move the patient, anytime we do an intervention, anything like that, we want to re-listen to lung sounds, check the line, make sure we're still at the teeth where we were prior to. That way we don't have a tube that comes out and now you're going into the epigastric region. So if for some reason you are having a hard time, or you've gone twice and maybe you don't have another medic, that can help you out. We talked about the bougie, okay? With this bougie, again, I can either use this or I can use my Mac or Miller blade. However, in my system, we don't use these for RSI, okay? I'm going to turn it on, same thing. I'm going to get it just to where I can barely see it in the right hand corner. Placement. We're going to get that right there in the molecular. There's going to be a end here that's a little bit curved, and that's the end you should be using. I was not using that end. Hit placement. We'll look for that vocal cords. Now, if for some reason you are not getting this, okay, you have about 15 seconds, and then you should be pulling out and oxygenating your patient, okay? From there, now that I know my tube is good, I can slide that right over, okay? I can push right through. And then I can pull this, and I can inflate. Listen to lung sounds, clear and equal bilaterally, and you're good. All right, and quick peek, and we are almost done. And of course, it's run out of battery. Here's what we're going to see when we talk about the vocal cords. Getting in there, we're going to look for that right there, and that's how we're going to pass our tube. I do apologize for having to move this around. It has been a little bit harder. If you guys were in front of me, obviously we wouldn't be doing that. That is my period of instruction, and I did go over about a minute and a half, but I hope you did learn something, and I hope that you guys can critique me. RSI is not my strong suit, which is why I chose to do this, to help me get better at this and doing what I'm doing and learning a little bit about RSI or DAI. So I do appreciate you guys, and I have loved this course, and it really has taught me a lot. So thank you very much.